Welcome to the Illinois Public Health Association Community Health Worker Community Capacity Center Colorectal Cancer CHW Patient Navigator Training. Funding is provided by Exact Sciences Corporation Focus Program, engaging community health workers to address colon cancer. In Module 4, we will discuss colorectal cancer screening. The objectives of this module include distinguish between a person at average risk or increased or high risk for colorectal cancer, identify resources for colorectal cancer screening guidelines, describe different types of colorectal cancer screening tests, and explain colonoscopy prep to a client. Early detection and screening means finding and diagnosing a disease earlier than if you had waited for symptoms to start. In Module 1, you learned terminology such as average risk and increased or high risk in regard to colorectal cancer. Let's discuss the American Cancer Society's screening recommendations for people at average risk of developing CRC. People are considered average risk if they do not have a personal history of colorectal cancer or certain types of polyps, a family history of colorectal cancer, a personal history of inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, a confirmed or suspected hereditary colorectal cancer syndrome, or a personal history of getting radiation to the abdomen or pelvic area to treat a prior cancer. Due to more and more people being diagnosed with colon cancer at an earlier age, the screening guidelines have moved up from 50 years to 45 years. Yes, 45 is the new 50. For average risk individuals, regular screening should begin at age 45. After age 75, individuals should discuss whether to continue with screening. Screening should end at age 85. People at increased or high risk of colorectal cancer might need to start colorectal cancer screening before age 45, be screened more often, and/or get specific tests. This includes people with a strong family history of colorectal cancer or certain types of polyps, a personal history of colorectal cancer or certain types of polyps, a personal history of inflammatory bowel disease such as ulcerative colitis or Crohn's disease, a known family history of a hereditary colorectal cancer syndrome, a personal history of radiation to the abdomen, belly, or pelvic area to treat a prior cancer. Keep in mind that not every patient may know their family's medical history. Therefore, please encourage your clients to regularly visit their primary care provider to assess their risk and need for screening as recommended. For anyone with high-risk characteristics, a colonoscopy is the only recommended screening. Healthcare providers look to different organizations for guidelines about when to screen patients for different diseases, including colorectal cancer. In addition to the American Cancer Society, the United States Preventative Services Task Force, or USPSTF, also has colon cancer screening guidelines. Not all organizations agree on exact guidelines, and the healthcare providers that you work with may have differing protocols based on these guidelines. This can be confusing to clients. Encourage clients to talk to their doctor to know which options are right for them. As a CHW, knowing where to find resources related to guidelines is key. You can scan the QR codes above or the links to take you directly to each organization's current guidelines. Keep in mind that guidelines change because new research is coming out continuously. It is a positive thing when we change guidelines to match the newest research. Genetic mutations play a role in how all cancers start. Most mutations occur during a person's lifetime, but some mutations can be inherited from a person's parents. Based on a person's family and personal history of cancer and/or the characteristics of the tumor, they may be referred to a genetic counselor to discuss if genetic testing is appropriate. For example, if a young woman is diagnosed with breast cancer and her mother and aunt were also both diagnosed with breast cancer at a young age, her doctor may order genetic testing or may refer her to a genetic counselor for testing. If they find a known hereditary genetic mutation, she may also be at increased risk for a breast cancer reoccurrence or ovarian cancer. This information can help her care team determine the best treatment for her to help reduce her risks. It can also help her family members make decisions related to their own risk. If a person gets diagnosed with another type of cancer, what is their risk for colorectal cancer? Research has shown that people with a previous personal history of ovarian, uterine, or breast cancer have a greater chance of developing colorectal cancer. The experts are still exploring the data and specific recommendations, but all patients with active or remissive cancer, as well as those in survivorship, should adhere to their doctor's recommendations, adhere to their treatment plan, including frequency of appointments, and ask their doctor questions about the potential development of secondary cancers and all types of preventative screenings. Now that we know when we should start screening, let's look at how often we should be screened. Recommended intervals for colorectal cancer screening tests include high sensitivity GFOBT, FIT, or Cologuard every year, sDNA FIT every 1 to 3 years, CT colonography every 5 years, flexible sigmoidoscopy every 5 years, flexible sigmoidoscopy every 10 years plus FIT every year, and colonoscopy screening every 10 years. Next, we will look more specifically at all of these screening tests. Now let's learn about how to use a Cologuard kit. How you prepare for a colonoscopy. Before a colonoscopy, you'll need to clean out or empty your colon. Any residue in your colon may make it difficult to get a good view of your colon and rectum during the exam. To empty your colon, your doctor may ask you to follow a special diet the day before the exam. Typically, you won't be able to eat solid food the day before the exam. Drinks may be limited to clear liquids. Plain water, tea, and coffee without milk or cream, broth, and carbonated beverages. Avoid red liquids, which can be mistaken for blood during the colonoscopy. You may not be able to eat or drink anything after midnight the night before the exam. You'll also take a laxative. Your doctor will usually recommend taking a prescription laxative, usually in a large volume in either pill form or liquid form. In most instances, you will be instructed to take the laxative the night before your colonoscopy, or you may be asked to use the laxative both the night before and the morning of the procedure. Adjusting your medications. Remind your doctor of your medications at least a week before the exam, especially if you have diabetes, high blood pressure, or heart problems, or if you take medications or supplements that contain iron. Also tell your doctor if you take aspirin or other medications that thin the blood, such as warfarin, which is also called Coumadin or Gentoban, newer anticoagulants such as Pradaxa or Xarelto used to reduce risk of blood clots or stroke, or heart medications that affect platelets, such as Plavix. You may need to adjust your dosages or stop taking the medications temporarily. Your client may be more concerned about the prep for their procedure than they are about the procedure itself. Questions to ask your client include, do you know what you need to do for prep for this test? What are you going to change in your diet tomorrow to be ready for your test? Do you need to take time off work? Do you have a ride to and from the test? Discuss and make a plan for transportation with your client. They should not drive until 24 hours after the procedure. If they take public transportation to and from the hospital, they need to be accompanied by a responsible adult. Most hospitals will not allow a patient to leave after they have been sedated for a procedure without a responsible adult present. Utilize the teach-back method when discussing these points with your clients. Colonoscopy prep isn't fun for several reasons, the main one being how much you will poop. You may have diarrhea for 12 to 16 hours after beginning the process of getting your bowels ready for this procedure. How long the colonoscopy prep process will take altogether varies, but passing clear or yellowish fluid that is free from fecal matter is an indication that your bowel prep is complete. The time it takes to get to this point largely depends on your general gastrointestinal health and how closely you followed your bowel prep diet. During a colonoscopy, you will wear a patient gown, but likely nothing else. Sedation or anesthesia is usually recommended. In most cases, the sedative is combined with pain medication given directly into your bloodstream intravenously to lessen any discomfort. You'll begin the exam lying on your side on the exam table, usually with your knees drawn toward your chest. The doctor will insert a colonoscope into your rectum. The scope, which is long enough to reach the entire length of your colon, contains a light and a tube that allows the doctor to pump air, carbon dioxide, or water into your colon. The air or carbon dioxide inflates the colon, which provides a better view of the lining of the colon. When the scope is moved or air is introduced, you may feel stomach cramping or the urge to have a bowel movement. The colonoscope also contains a tiny video camera at its tip. The camera sends images to an external monitor so that the doctor can study the inside of your colon. The doctor can also insert instruments through the channel to take tissue samples or biopsies or remove polyps or other areas of abnormal tissue. A colonoscopy typically takes about 30 to 60 minutes. After the exam, it takes about an hour to begin to recover from the sedative. You'll need someone to take you home because it can take up to a day for the full effects of the sedative to wear off. Don't drive or make important decisions or go back to work for the rest of the day. You may feel bloated or pass gas for a few hours after the exam as you clear the air from your colon. Walking may help relieve any discomfort. You may also notice a small amount of blood with your first bowel movement after the exam. Usually, this isn't cause for alarm. Consult your doctor if you continue to pass blood or blood clots, or if you have persistent abdominal pain or a fever. While unlikely, this may occur immediately or in the first few days after the procedure, but may be delayed for up to 1 to 2 weeks. The most important thing is to get screened, no matter which test is chosen. Encourage your clients to talk to their healthcare provider about which tests might be a good option for them. Summary, we can now distinguish between a person at average risk or increased or high risk for colorectal cancer. We know that there are multiple places to find current screening guidelines, including the American Cancer Society and the United States Preventive Services Task Force. We can describe different types of colorectal cancer screening tests, including Cologuard, FIT test, sigmoidoscopy, and colonoscopy. Remember, it is not your place as a CHW to determine which screening test is right for your clients. However, you can explain the different screening tests and encourage the client to talk to their doctor about which screening test is right for them. Lastly, we know that if a client has to have a colonoscopy, they may have lots of questions about not only the procedure, but also the prep. You can help make sure that your patient is prepared to have their colonoscopy prep completed correctly, as well as assist them in arranging transportation to and from the hospital on the day of the colonoscopy test. There is a lot of misinformation about colorectal screening tests. Your toolkit will have many resources for you to refer to and help you educate your patients.